You're looking at this gorgeous shot just a few feet away from where we're standing here in San Diego. You know, there have been some significant changes to reimbursement for PCI. Most non-acute procedures are paid for at lower outpatient rates. So we have an NCDR analysis looking at downstream effects of these changes on clinical practice that really have not been studied at this point. So it's temporal trends in admission status and predicted mortality among patients undergoing non-acute PCI, and I'm with Dr. Amit Vora, MD, a third-year cardiology fellow, and very happy to be back with Dr. Sunil Rao, who is an associate professor of medicine. Now, for some background, why did we do this study?
So, Rick, you're right. There has been a lot of change in the way we pay for PCI, and primarily it's been the shift from inpatient reimbursement to outpatient reimbursement. And it's interesting because that's really hospital level reimbursement, and a lot of physicians aren't aware of the differences. The inpatient versus outpatient really is simply a billing designation. And inpatient PCI procedures are reimbursed at a much, much higher rate than outpatient procedures are. And it turns out that outside of a myocardial infarction, almost every PCI is really considered an outpatient procedure. In the past, because of that increased reimbursement, hospitals were potentially incentivized to bill all procedures as inpatient procedures. But Medicare said, if you're doing that, we're going to come and audit you, and we're really going to levy some steep penalties. So then there was the opposite incentive to maybe say every single patient is an outpatient now, no matter how high risk they are. From our own experience, we've noticed that these outpatient procedures are being performed in higher and higher risk patients. They're older, the procedures are even more complex. And clinically, we felt that there are some patients who really should perhaps stay in the hospital a little bit longer and even be considered for outpatient or for inpatient reimbursement because they may need some counseling and some secondary prevention. So we wanted to see if our experience really is in fact what's happening out there. Are these patients who are all considered outpatients by payers, is their risk profile increasing over time? And that was really the crux of the study.
So what did you find? Because this is a large analysis, right?
Yeah, I mean, absolutely. With the NCDR, with the Cath PCI registry, our initial patient sample was more than 3 million patients at more than 1,500 sites. Now, after excluding the patients that met an inpatient indication, so underwent PCI for acute MI, we focused on the just under 1 million patients, again, at over 1,500 sites across the United States. Now, these 1 million patients all would classify or would qualify for reimbursement at the outpatient rate. Of the 1 million patients, a little bit more than half were admitted after PCI, with the remainder not being admitted after PCI. Among the patients that were admitted after PCI, they tended to be older, they tended to have greater comorbidity, they tended to have more complications after the procedure, they tended to have more complicated procedures, more bifurcation lesions, more AHA-ACC type C lesions than patients not admitted after PCI. Across our study period, which went from 2009 to 2014, we've noticed that the proportion of patients admitted after PCI fell markedly from more than 2/3 to just around 1/3 of patients. The patients that were admitted after PCI had a longer length of stay as well, that went from about 2.5 days to a little over 3 days. And then when we risk stratified these patients by high, intermediate, or low risk for predicted mortality, the patients that were admitted after PCI had there was a greater proportion of patients at high risk for mortality, a high predicted risk for mortality over time, such that by the end of our study period, which was Q2 of last year, close to 40% of those patients were at high risk for predicted mortality. There was, interestingly, about 20% of patients at low risk for predicted mortality that were admitted after PCI that perhaps may not need to be admitted. Conversely, there was about 17% of patients at high risk for predicted mortality that were not admitted after PCI. And those patients may actually benefit from inpatient admission.
Now, with so much more emphasis on trying to get these patients out the door as quickly as possible, this is encouraging, isn't it?
So I think the implications of this is that despite the reimbursement scheme, clinicians are doing the right thing. They're trying to do the right thing. Right. They're looking at a patient in front of them. They're not paying attention to the outpatient versus inpatient designation, and they're saying, look, this patient is at high risk for predicted mortality. We're going to go ahead and admit them. Our analysis, I think, really argues against a sort of universal approach to reimbursement.
Yes.
Rather than saying this procedure or that procedure should qualify for inpatient or outpatient, because of the existence of robust risk models like the NCDR Cath PCI risk model, why not have a risk-based approach? We capture all that data through NCDR Cath PCI. We're able to designate a patient as being at high risk for predicted mortality. Because of the resources that are expended in taking care of those patients, our position is maybe a risk-based approach to reimbursement is more reasonable than just a universal inpatient versus outpatient designation.
So you can take this paper and Jack and point to the executives and say, look, we actually know what we're doing.
I think that's right, and I think this is a paper that I think not only informs clinicians, but you're right, it informs the administrators, and we're hoping that it actually informs the payers as well.
And this paper, as I said, is coming up from the NCDR. It's from the ACC 15 meeting. And if you want to find out more about what's going on at the ACC 15 meeting, please see CardioSource World News, where I am Executive Editor Rick McGuire.